on to lung cancer. I'd like to welcome Dr. Carbone from the Ohio State University, and he just meeting him this morning, but he may not be aware. When I was there finishing up my training, there was real excitement to pull him away from Vanderbilt to come up at that time and work in translational research. So we are looking forward to hearing your talk today.
All right, thank you very much for the invitation. It's hard to follow Heinz Lenz in any respect, but I'd like to posit that lung cancer is the disease with the most exciting advances in the last decades. And I've been assigned the topic of adjuvant versus neoadjuvant, which is an exciting new development in the disease. These are my disclosures. So surgery is still the intervention most likely to cure lung cancer, but if you look at the operable stages of lung cancer, especially, I should have extended that box down to 3Bs, 24% 5-year survival for 3Bs, 40% for 3As, and many times those patients didn't even get surgery in my training. Lots of room for improvement. This is the chemotherapy study that showed that adjuvant chemo showed benefit after surgery. Most of these patients were not 3Bs or 3As, but if you look, there's only about a few percent difference in survival from cancer-specific cause. And again, look at those curves. They go down to less than 50%, 5 years, but it also increased non-cancer death by 1.4%. So there's two new classes, major classes of systemic therapy that have shown dramatic results in metastatic disease. Can they be applied to early stage disease? In order to move them into early stage disease, generally we want them to improve survival in advanced disease and be well tolerated enough to be safe for those who can be cured by surgery alone. We got a hint that after definitive therapy, immunotherapy might improve outcomes with this trial, this specific trial. This is immunotherapy after chemoradiation therapy. It's the first trial to show a survival benefit in this context ever. And it shows about a 10% improvement in 5 years survival after chemoradiation therapy with a year of durvalumab. This is now standard of care. So let's start with talking about adjuvant trials. There's lots of adjuvant trials of immunotherapy. I'm going to talk about a couple of them. One is Empower 010. This is adjuvant atezolizumab after complete surgical resection and chemotherapy for stage 1B to 3A. This is a year of atezolizumab versus best supportive care. These are the survival curves for this study. If you look in the upper left, the intention to treat in all stages is absolutely zilch. There's some signal in the PD-L1 greater than 1%, but there's convincing benefit in the greater than 50%. This drug is approved in greater than 1%, but the entire benefit is driven by the very high PD-L1s. If you look at 1 to 49, this is really not effective and potentially toxic. So if you look in PD-L1 negatives in this study, really it seems like there's even harm to adding adjuvant. So the lesson there is some benefit, but it's especially in PD-L1 highs with adjuvant atezolizumab. If you look at ctDNA, patients with positive versus negative ctDNA, clearly prognostic and impacts survival in both arms. The other adjuvant trial is this Pearl's Keynote trial. This is Pembro after surgery. This is also a trial that was positive and had and is approved in all PD-L1s, but again, pretty unimpressive results in the intention to treat, and we have some wingdings going on here, but it does seem like this is the greater than 50% population. So really it's very different from the Empower 010 study. And this is patients, a subset of a subset where it's positive, but really overall my take on this is it's very unimpressive. And even though it's approved for all PD-L1s, it's not a game changer. This is, in fact, the overall survival from that study. Really unimpressive to me. What about neoadjuvant immunotherapy? We've talked a little bit about it with GI cancers. You know, postoperative IO has advantages of no delay. We have more accurate staging. Surgeons hate delaying surgery. But preoperative IO really has the ability for us to assess anti-tumor efficacy of our intervention, early systemic therapy, but importantly, I think intact nodal drainage in the tumor is there, and it might benefit to induction of an immune response, and we can get biospecimens in that settings. So I think a landmark study is the neoadjuvant trial Checkmate 816. This is 3 cycles of chemo-nivo. I'm not going to talk about the ipi-nivo arm. 3 cycles with no adjuvant therapy. The path-CR rate for this study was 24% versus 2% for the chemotherapy. And this is the event-free survival. I think clear improvement in event-free survival. And if you look by subgroups, it was better in stage 3s. It was effective in both squamous and non-squamous. And actually, at least the point estimates are better for all PD-L1s. And if you look, there's now a 4-year survival update for that study with a clear benefit in survival and overall survival and lung cancer specific survival. And if you look at the actual numbers here, you're now seeing 70% alive at 4 years in this study, which is pretty remarkable in the context of surgery of the stage 3s. What about adjuvant immunotherapy after neoadjuvant? There's many studies that are looking at adjuvant immunotherapy after neoadjuvant chemoimmunotherapy. Several of these have read out. Keynote 671 is a study with neoadjuvant pembro chemo followed by a year of pembro. This is event-free survival, hazard ratio of 0.59, quite impressive improvement. Overall survival is statistically significant with a 4-year overall survival of 67%. And this is also effective in every subset, N2 or not N2. Historically, we would never operate on an N2 positive patient, but now even multi-station resectable N2s are included in these patients and in all PD-L1s. Checkmate 77T is the nivo equivalent chemo-nivo surgery followed by adjuvant nivo. Again, EFS looks impressive. We don't have overall survival, but it's especially impressive in the stage 3 patients. Again, these are patients who we wouldn't even take to surgery in the past. We're now showing very decent survivals and some more wingdings, but the benefit's greater in the positive PD-L1s, but even there in the negatives. And this is for stage 3 N2 patients, single station and multi-station N2. Look at the benefit in multi-station N2. So instead of it being an unresectable situation, now we routinely resect multi-station N2 after neoadjuvant. So this is kind of an unfair cross-trial comparison, but really looking at how all of these trials, including the first one, 816, which is neoadjuvant only, almost identical with all of the ones with neoadjuvant and adjuvant. 71% 4-year OS for 816, 67% 4-year OS if you add a year of pembro. So really, they're all about the same, and honestly, in my practice, I use 816, 3 cycles of neoadjuvant and stop. And this just shows the same thing, that really all of the outcomes are almost the same for all these studies, including neoadjuvant only. So there's lots of remaining questions, no head-to-head trials. We don't know if adding adjuvant to neoadjuvant is better. In my opinion, Neoadjuvant is clearly better than adjuvant, and we should really be looking at that as a standard of care. Adjuvant is only a mop-up if you happen to operate on someone and find oops N2, for example. We don't know if IO monotherapy or IO chemo is better. We don't know how long to treat these patients. We don't know if we want to make treatment decisions based on path CR or not. We don't know whether postoperative radiation, just approved by the Thoracic Malignancy Steering Committee, is a study in post-op radiation, and if patients have residual N2, what do you do in driver mutants? What do you do on relapse? We need biomarkers. Just want to quickly present a study I led. This is called LCMC3. This is 2 cycles of atezolizumab alone before surgery, just 2 cycles. And the outcomes in this study I've compared. We now have 4-year overall survival data for this study. If you compare it to the Keynote 671 or historical survivals, it's a 180 patient study. Look at the survival of those 2 lines on the right are stage 2 and stage 3 patients. Look at the survivals of those patients compared to historical survivals shown below. 71% 3-year survival in Keynote 671. We had 82% 3-year survival in stage 3 lung cancer with just 2 cycles of neoadjuvant atezo. And so I think this is clearly showing neoadjuvant is effective, and we may not need chemo in all patients. And this was not dependent on PD-L1 either, by the way. We did a lot of correlates in this study. We came up with a predictor of MPR based on blood immunophenotype. I don't have time to go into all that. We looked at ctDNA, and it turned out that on the far right you can see if patients had a major pathologic response and clearance of their ctDNA, they had 100% 4-year survival. So I'm going to touch briefly on targeted therapies and added to immunotherapy. It doesn't have an illustrious history. This is a trial I remember well when dinosaurs roamed the earth, where we added EGFR TKIs after chemoradiation, like the Pacific trial. The survival was not only not better, but it was actually statistically significantly worse. So this is not a good start. There are multiple other adjuvant trials. This is a Chinese trial showing disease-free survival after adjuvant gefitinib versus chemotherapy. You can see there's some separation of the curves early on, but they come together and there's no DFS advantage and no OS advantage. Now that's been changed a little bit with this trial. This is ADAURA. This is adjuvant osimertinib versus placebo in EGFR mutant stage 2 and 3A disease. Hazard ratio 0.23, with 3 years of therapy. But you can see after 3 years, those curves start to come together again. And I wouldn't be surprised at all if 5, 6, 7-year survival, there's no difference. But a dramatic difference in disease-free interval with adding osimertinib in patients after surgery with EGFR mutations. But you can see still there's about 30% of patients that do just fine on the placebo arm, which means that they would have been cured, and they're getting 3 years of $200,000 a year therapy for no reason. Now, this is a study that does have a significant overall survival benefit to adjuvant osimertinib after EGFR mutation, but the fact is in this study that osimertinib was not provided to patients in the placebo arm when they relapsed. Many of these patients were enrolled in countries where osimertinib was not available. And it turns out about a third of, most of these patients didn't get OC, about a third of patients on relapse got no treatment at all. And so we know for a fact that if you don't treat a metastatic EGFR mutant lung cancer patient, they're not going to do as well as if you give them osimertinib. So when I reviewed this paper for the New England Journal, I asked the authors to give me the survival of patients treated with osimertinib appropriately at progression on the control arm, and the authors refused to do it, and they published it anyway. So I'm not 100% convinced that this has a survival advantage if you follow your patients and treat them appropriately, but these are the data and it's approved. Similarly, adjuvant alectinib with ALK fusion mutant positive disease is now approved. There's a DFS difference. So far, no overall survival difference again, but clear benefit in disease-free survival, intracranial progression, and so you could argue that that's benefit enough. So the take-home messages for my talk really are combining immunotherapy with surgery is a new standard of care, will improve overall survival in early-stage disease, and really I think that neoadjuvant immunotherapy is definitely the way to go. You should educate your surgeons that all patients, especially in my practice, any N1 or N2 positive, N1 positive stage 2 or N2 positive stage 3 for sure should have neoadjuvant chemoimmuno. Still don't know all the details, duration of therapy, benefit of adjuvant, whether we should do anything different on PathCR or not. There are trials going on to discuss those things. We need better biomarkers to pick patients who need all this therapy. There's clear event-free survival benefit of TKIs after surgery. To me, OS benefits are unclear, but there is a benefit to not relapsing, so I do offer it to my patients. And that's it. Thank you.